Dr. Samir, can we start?
Yeah,
Yeah, okay, great. Sounds good. So, good evening, everyone, and thank you all for joining once again. And I'll just start by sharing my screen. Now, some of you have done this before. So, second. But those who are new to this, let me just run you through uh, the CaReMe Pro 2025 program. Now, again, just to tell you, this is the last, the final episode of this series, and I think today, we have not only a great guest but a personal friend of mine. And I think when we envisioned this topic, the person I had in mind was Dr. Mohammad Shafi Kuchay, Dr. Shafi, and I'll tell you all about him. But before that, just a quick word about the program. And again, like I said, a lot of you have already joined us earlier, so you're well aware with the flow. So what you're seeing right now is the live webinar session. It will also be, there'll be a recorded version of this also. You can go back and listen to it again. We have on the technocranology.com platform, you have all the materials, you have the case, you have all the, the video, everything there for you. So you can go back and again have a look at it again and have a see at that again if required. We put the case on the webinar chat. It's also available on the Technochronology platform. But we'll be discussing live. And again, standard housekeeping rule: if you have a question, please don't raise your hand. Just put it in the webinar chat, and we will be taking your questions as we go along. And also, we'll allow in the end allow you to unmute and ask your question to our expert today, right live. So this is the fourth part of the series today, and we, actually there's a little change in the dates. So it was supposed to be we're skipping this week, but we managed to make it happen. The first part, and each of them was better than the. I think this is a testimony of the fact that we had great interaction in all of the sessions. The first one we had with Dr. Gagan Priya. The second one was with Dr. Srinivas Kudwa. Fantastic session, both of them. Very lively. And this last week we had a session with Dr. Arun Kumar, the nephrologist. And this week we have an endocrinologist again, but not just any endocrinologist, the endocrinologist who is the expert on this topic, right? So the technology way, we already discussed this earlier. We have the Shravan, the Manan, and the Nidhyasan. The Shravan is where you, go through the case material and attend the webinar, which you're doing. There are additional material which is there. Manan is the quiz, so it's there on the technology platform. You can test your knowledge through that quiz. And Nidhyasan is what you reflect on, what you learn. And if you go to the technology platform, you will be able to see some material there, which is some sort of a template which you can use in your clinical practice based on the discussion which we are going to have today. So you can access all this content here. We also put the link in the chat, and it's simple, technochronology.com. Just go there, look at, search for the CaReMe Pro, and just sign up if you're not done so already. Okay. And again, important announcement today is that today is the last part of this. So you will get a certificate of participation. And this is what a certificate would look like. So to get the certificate, there are two ways of getting it. One is you will be able to get it on the platform itself. Every certificate will have an individual identity and a code. So you'll be able to download the certificate as a PDF from the technochronology.com platform. But you'll have to go through each and every section of the course. Just if you've seen it before, just click on the complete button. And if you finish all the sessions and the quizzes and the reflection, you will be able to download the certificate in the end, right? So that's how it works. Some of you again have attended our earlier sessions also on this topic. But additionally, there's another way of getting the certificate is you can contact your local Zydus Dapagliflozin division, representative, and they will give you a certificate in person. We'll be, of course, trying to reach out to each of you who have signed up to give you a certificate in person. But again, if you in case there is a miss out, please get in touch with someone from Zydus, and they'll be able to get you this, right? Once again, we thank Zydus Healthcare for being generous in providing this. It's an educational grant. Again, there no editorial touch on this. Of course, SGLT2 inhibitors are going to be discussed. So that's you can say conflict of interest in a way, but at the same time, there is absolutely nothing in terms of it's a live session. there is no editorial input from the pharma company. It's a completely neutral session from that perspective. Another thing, for more sessions, we are going to have a session on heart failure very soon, again with Zydus, a series of lectures on heart failure. So again, if you want to be updated on the same, this is the Endocrinology India WhatsApp channel. Just go through that, and you will be we'll be putting all the updates there as we go along. Okay, so with that, let me introduce our expert today, Dr. Mohammad Safi Kuchay. Now, before I introduce him formally, let me tell you a little story. So I know Dr. Shafi when I was a student in endocrinology in Delhi, right? I know him from that time. He was a senior to me. He of course guided us in a lot of things in endocrinology. He was somebody we looked up to. So not only is he a personal friend, a personal hero to me, and that is what I would say. And then getting back years down the line, I still remember, us having a nice little lunch chat in New Orleans. I don't know if he remembers this. Yeah,
Yeah.
in New Orleans. So both of us were at the ADA in New Orleans, and we had a very nice little lunch. And he told me a fascinating story. And let me tell you, this it was special because sir was one of the rare speakers from India at the ADA, right? And I think it was a rare honor. And I think, right center stage at a very important session on MSLD, that was called NFLD then, uh, uh, based on his work, based on the ELIF trial and his work in that. And I think it's a landmark work. Uh, I think time will tell the testimony of the importance of the work he has done. Of course, there are subsequent, there's a great work, I and him both, we have a lot of interest in hospital hyperglycemia. So there's a great work by him on that topic as well. But that's a subject for another topic. But I think his seminal work really comes from his important work comes on his work with the use of SGLT2 in MSLD. And I think that's a game changing thing. This is the first paper on this from India, from the world, right? Not just from India. And that I think well earned place in the ADA history books. And it told me a very fascinating story about the trial, about how it started and how we ended up in New Orleans with Dr. Shafi presenting his work. So I think that's a great thing. And I think for this with this topic right at the beginning, when I envisioned it, the only person I had in mind was him, right? So that's the whole thing, right? He's a consultant endocrinologist at Medanta in Gurugram. He completed his MBBS and MD from Acharya Sri Chandra Medical College of from Jammu, and he did his DM from Sher Kashmir Institute of Medical Sciences from Srinagar. Sir specializes, as you can see, in MSLD. Absolutely, right. So, the endocrine aspects of MSLD and MSLD in general. But besides that, diabetes, thyroid, pituitary disorders, adrenal diseases, osteoporosis. Again, great interest in, like I said, hospital hyperglycemia. He is also the editor of the Diabetes and Metabolic Syndrome Journal, the Clinical Research and Reviews Journal as well. I think a lot of accolades, a lot of work, very strong researcher. It's a absolute privilege of having you today. Thank you so much.
Thank you, Dr. Om. Thank you for having me.
Thank you. So we begin today session. Just give me 1 second to share the slides. And like we've done earlier, we will be discussing the case as we go along, and we will be taking the inputs from all of you as well as from our expert today, Dr. Shafi. And if you have any questions, again, we'll be taking some poll questions from you as well. But if you have any questions to ask to our expert today, please put it in the chat, and we'll be taking that at the regular intervals. When we go along, right? Okay. So today's case is on something beyond glycemic control. We are going to see the role of SGLT2 in general, Dapagliflozin in specific, but more again SGLT2 in general in type 2 diabetes with MSLD, right? So that's the topic which we're going to do today. Okay, right. So we all know about this, the entire thing, but let me then take you straight to the case. So the case is of a person called Mr. Vikram Sharma, who is a 48-year-old IT professional from Bangalore. And on a routine checkup, he was found to have MSLD during his routine evaluation. He was already having type 2 diabetes, and that's what this is his case, his story that we are going to discuss in depth. So let's talk about Mr. Vikram Sharma, right? So Mr. Vikram Sharma is age 48. He works as an IT professional in Bangalore, and he often presents he has a sedentary lifestyle like a lot of these people, long hours at desk, minimum physical activity. He has a very strong family history of type 2 diabetes and cardiovascular disease. He has multiple family members with this disorder. He claims generally that he does not have much of alcohol, less than 20 grams a day, or just an occasional social drinker, as he claims. And just generally, in terms of symptom, has just a little bit of fatigue, a mild upper quadrant tenderness, discomfort, but generally mainly fatigue, which has been gradually worsening over a few times. And fatigue is a very, sort of a common symptom for many of these disorders, right? So we did his initial evaluation and his BMI is 29, which is clearly overweight. He's having central obesity with a waist circumference of 98, blood pressure slightly elevated to 138. He has a mild hepatomegaly, acanthosis nigricans are very clearly present. His HbA1c is 8.2. His SGPT, SGOT, his ALT, ASTs are elevated. GGT is also elevated, and triglycerides is typically in 180s with the EGFR of 92. Right. So this is his initial lab workup. And of course, to make a diagnosis and establish the diagnosis of MASLD, it's a diagnosis of exclusion to a lot of extent. So other causes were ruled out. So the viral and autoimmune markers were negative. An ultrasound showed a grade 2 hepatic steatosis. And also a fibroscan was done, which showed a liver stiffness, the LSM value of 7.8, which suggests F1 to F2 fibrosis, mild to moderate, and a CAP value of 310, which suggests S3 steatosis, right? And a FIB4 score was calculated from his parameters, and the value was 1.42, which again puts him in a intermediate range in terms of the FIB4 score. Now, I'll go to Dr. Shafi and sir, in your practice, how do these patients with MASLD typically present to you in clinical practice? And what are the things you look for? What are the things you evaluate? And is this a fair evaluation of this patient?
Yeah. Okay. So as I'm in a tertiary care center, most of our patients have complicated diabetes and have comorbidity. They have obesity, they have hypertension, dyslipidemia. So most of our patients have fatty liver. Whether they have developed fibrosis, that is a separate question. But in my practice, about 70% of patients have evidence of MASLD. Okay.
Right.
Most of these patients come with investigations, and they have elevated enzymes, SGOT, SGPT. Sometimes they come with ultrasonography of grade 2 or grade 3 fatty liver, and fibroscan is not done. Sometimes some patients come with fibroscan and they come that I have this. Most of the times it is ultrasound abdomen that they come to know that they have fatty liver or abnormal enzymes. So this is the usual presentation. But as I said that we get complicated diabetes patients, I know that I have to screen everybody because almost everybody has some evidence of fatty liver. So we have to screen patients. We have to see patients. You will get, it may not be 70%, 80% in the, physician's clinic in the community level. It may be less, but in a tertiary care center, it is very epidemic. Problem is very epidemic.
Right. And how do you, define, broadly in your practice, a quick, again, review of how would you define a patient as having MASLD per se? Would you just focus on the liver enzymes or the ultrasound characteristics or what would be your parameters to say that this patient surely has MASLD? Okay, I think we lost Dr. Shafi. Probably there is some electricity issue. Okay, so while he comes, Dr. Samir, are you there? Let's take this discussion forward with when he joins. Dr. Samir?
Yeah, I'm here.
Yes.
Very much here.
Yeah. So, Dr. Samir, we know that Zydus Healthcare as an initiative often does a lot of fibroscan as a part of the practice. So again, to which type of doctors do you really offer a fibroscan? And from what you've done over a period of time, I think again Zydus has been pioneer in providing fibroscan as a tool for a lot of doctors. What have you learned over the years from fibroscan?
So primarily as a strategy, we have been offering fibroscan machines to diabetologists, physicians, The whole objective is, as we know that NAFLD, now popularly known as MASLD, has been quite an underdiagnosed condition actually.
Yes.
So the more the awareness, because we know that at the end of the spectrum, it's not only fibrosis, but it's cirrhosis and hepatocellular carcinoma, which is going to be very fatal. So our objective was to enhance the diagnosis of MASLD and try to have the optimal treatment. And we have been doing this since quite a few years now. And we've got a good response from doctors all over India. And they have really considered this as a noble cause because we have got good diagnosis of MASLD at the early stage, because we
Right.
know that a fatty liver finding on an ultrasound may or may not be coupled with elevated liver enzymes. So normal liver enzymes may also not rule out fatty liver.
Right.
And the converse, where I would have elevated liver enzymes, would necessarily not suggest MASLD. So FibroScan is one investigation which we thought would help the population and doctors also. And we are also trying to create a lot of awareness amongst doctors.
Hello.
Yes, Dr.
Even
Shafi,
Dr.
we can see
Mohammad
you
Shafi
back.
Sorry,
is
Thank
here.
sorry,
you.
there was some electricity issue. So
Yes.
I'm now from the mobile, but it's
Okay.
okay.
Yeah, we can see
Am
you.
I?
We can see you. We can perfectly
Okay,
see you and hear
okay,
you. Yeah. Okay. So,
okay,
so
okay.
Dr. Shafi, we are discussing about MSLD per se and the role of fibroscan. So, which patients do you send them for a fibroscan, if you do?
Yes. Uh, we do FIB4 scoring for all patients.
Yes, that's
Those
wonderful.
who have, FIB4 score of more than 1.3,
Yes.
we said, we discussed with the patient and almost offer fibroscan to all the patients,
Right.
above 1.3, below
Okay.
1.3. And with this scoring, you take almost 70% of our patients who have fatty liver evidence. So you don't have to send them for fibroscan. So
Right.
almost 30% patients have FIB4 above 1.3, though you send them for fibroscan.
Okay.
This is your sequential is very important. Otherwise, you can't send all the patients, 100 patients to the, fibroscan.
Right. Absolutely. So you calculate the FIB4 score, and if it's more than 1.3, like sir rightly said, that's the patient who becomes a candidate for a fibroscan, right? So this patient, if you see, this patient had type 2 diabetes, Mr. Sharma, and he has metabolic dysfunction associated steatotic liver disease, MSLD. He has severe steatosis. So this patient, we did a fibroscan because his FIB4 score was 1.4. So like Dr. Shafi said, he becomes a
Yeah,
candidate for a fibroscan. And we did that, right? And he had a mild to moderate fibrosis with a severe steatosis. He also has hypertension, diabetes already, and dyslipidemia, all of which point to metabolic syndrome. So this is the diagnosis which we established. Now we'll take an audience poll, and then we'll take the views of Dr. Shafi also. So let me just give me a second to just run the poll quickly. Right. So let's take this question. So for a patient like Mr. Sharma, so we saw this, dear audience, he has type 2 diabetes, he has MSLD with steatosis, fibrosis, HbA1c of 8.2. What would be your preferred pharmacological therapy beyond metformin and lifestyle advice? So would you give this patient a pioglitazone, a GLP-1, SGLT2, or a DPP-4 inhibitor? And Dr. Shafi, let's just dive into the topic, which you are the expert. The role of SGLT2 in MSLD. How did you envision this? A little bit about the ELIF trial, and then
This,
would you
okay.
consider the same for this patient?
Okay. So, I joined Medanta as an associate consultant in, November 2014. And
Yes.
at that time, it has not come in the Indian market. So it was one of the hot topics for our, exit examination as a DM.
Right.
That what are the recent advances in diabetes?
Right.
So we had learned a lot. Then I joined, and after 6 months after my joining as in the Medanta, in May 2015, Empagliflozin was launched in India.
Yes.
for the treatment of type 2 diabetes. And
Yes.
dapagliflozin was also, launched in that period. So I was at that time working under Dr. Mittal. So I was seeing his patients, and when he, prescribed this medicine, I saw some changes in, SGOT, SGPT, in some, improvement in those. And as I have in mind that, it is patients lose some weight, and I have read preclinical studies that in mice, this empagliflozin and dapagliflozin, they cause, they reduce the liver volume in rat. So it was in the back of my mind that it has something to do with fat in liver. So at that, after 6 months, in November 2015, I started, saying what should I do, because at that time I understood that I should have some major modality which measures liver fat. You can't
Right.
do this type of study with ultrasonography because that's a vague measurement of fat. You can't
Absolutely.
do biopsy of all patients. So in the meantime, one of our excellent radiologists, Dr. Sonal Krishan, that is the second author in the ELIF trial, she had learned this MRI PDF. It was not common at that time. Only in America it was done in 2 centers only. It was not available. She had learned this in UK. She has read from UK.
Okay.
So she developed this technique in Medanta. So when I came to know that MRI PDFF is very accurate fat measurement device, so then I, went to Dr. Mittal and said, I want to do this study. And he is very, generous. He, said, go for it. I will do funding. I will arrange money for this. And then the story began. It took us 2 years for the study. And it was then in 2018 that we published this in, Diabetes Care. And my also presented this in Chicago in 2018 Endo meeting.
Right, sir. So great story. And I think, am I right that this was the first clinical
Yeah.
trial to
Yes.
show the role of SGLT2 in the world? First clinical
This-
trial in the world to show the role of SGLT2 in MSLD.
Yes, this was if you read this full, that paper, it was the proof of concept study, first
Right.
study. We
Right.
showed that, yeah. And after that, after 1 year of this study, another group from Finland, Dr. Latva Raisu, done study on dapagliflozin, we showed the same thing.
Right.
Same magnitude of liver fat reduction and same magnitude of AST, ALT reduction. And now we have 5 studies in EMPA, 5 studies in DAPA, and all other MRI-based studies. We showed that it's a class effect. All molecules, they reduce it persistently in all studies. And I am giving you news this for the first time that one study in China done on dapagliflozin, which is a biopsy-based study, year-long, long term. We showed that this group of dapagliflozin reduces liver fat, improves NASH, and also improves fibrosis. And
Right.
that is better than resmetirom and better
okay.
than GLP-1 receptor agonists. It is
Wow.
accepted. It will come in BMJ in next month.
Landmark. So that will be a landmark study, right? Because then you're proving
that will change. That will make SGLT2 inhibitors as
the first line drug.
First choice. Yes, first choice.
First line drug.
So
Okay.
that the thing that I started in 2016 is now this will be the final. Yes.
Nail in the coffin. Yes.
Yeah.
So absolutely great. So I mean, this is amazing. I think this is just outstanding. And I think, we don't often talk about Dr. Shafi. I feel personally this was, we don't talk about our own Indian innovation. And I think one thing which I think is the in our field, the field which we are, I think one of the biggest stories which I have lived through is this trial by Dr. Shafi. I think it's an amazing innovation. I think we should all be applauding this work which he started, which is now going to be, taken forward to a level where SGLT2 becomes the first line agent for MSLD, outshining the other drugs like the GLP-1 RA and resmetirom, which again resmetirom is the first and only drug right now to be given approval for MSLD in the United States, right? So that's the story right now, and I think soon this may eventually change. So I think the audience is also in agreement with the same. Again, a lot of them are proposing that SGLT2 inhibitor should be the first choice in this patient. A little, let me play the devil's advocate. And you said that the study from China is going to say that it's going to be better than GLP-1, but GLP-1 is also emerging fast as a very important drug to be used in MSLD, right? So, what's your take? You're an expert in this. Your take on GLP, its role in MSLD.
Yeah, GLP is a very important group of, we don't need only one class of treatment.
Yes.
MASLD is like type 2 diabetes. Even
Right.
if you have 5 class of drugs, you still want more because the burden is such that all patients don't, they don't respond uniformly to all medications. Some
Right.
respond to some group of treatment, so you should have many, weapons in your armamentarium. Then patient selection is very important. So as you showed, pioglitazone, GLP-1, SGLT2, all have their place in the treatment of MASLD. So GLP-1 receptor, for example, if this patient had BMI of more than 35 kg per meter square, I would initially think of GLP-1 therapy after metformin, so that when this patient, we need more weight loss, not just 3-4 kgs, we need 10-15 kgs weight loss. So GLP-1 are now dual agonists, they will be more beneficial than SGLT2. But most of the patients we have, they are overweight, and SGLT2 has other I will just after some time I will tell you other insight into this disease, why SGLT2 inhibitor or GLP-1 receptor are better drugs, because we'll discuss that later. But
okay, sure.
Yeah.
Okay, great. So moving on to the topic, and we already addressed the topic here about the role of SGLT2. So this patient, let's see what happened to this patient. So this patient was given this treatment. So of course, a caloric restriction was suggested, a Mediterranean diet was suggested, but of course, very difficult to follow in India. The patient was suggested moderate exercise. 7 to 10% weight loss was the target weight loss, which was discussed, which is part of standard of care. Now, this patient was discussed, like Dr. Shafi said, apart from metformin, pioglitazone, GLP-1 RA, and SGLT2, all the three drugs have some sort of proven role in type 2 diabetes and MSLD. Of course, because of the cost benefit and because of the easy availability, SGLT2 was thought for this patient, and he was offered the same. So this patient was continued on his metformin, which was gradually increased to a full therapeutic dose, and a Dapagliflozin 10 milligram was added. And of course, the importance of SGLT2 and the side effects were considered. Dr. Shafi, let me play a little bit, again, a devil's advocate here as well. Now, when you did the ELIFT trial, right, I'm sure this question would have come up, and, in a sense, at that time, pioglitazone was well established for its use in type 2 diabetes with MSLD. Why then would you not give pioglitazone and consider SGLT2 in such patients? So where do you stand between pios versus SGLT2?
At that time, it is 2016. Nobody in the world, we are considering MSLD as a disease.
Right.
It is now common for last 3-4 years. Then we have that guidelines and algorithm.
Yes.
In 2016, nobody was. We were just seeing fatty liver, and no, we are not giving any thought. So nobody was prescribing pioglitazone. So at that time, because we were doing nothing, I started doing this as a study. So
Right.
nobody was, going to tell me why you are not using pioglitazone.
Right, right,
So
right.
at that time, it is this. Now,
Yes.
if I do same, I will think, why should I give, this therapy because it has advantage. At that time,
Right.
because there was no therapy. So,
Right.
that question was not in my mind at that time.
Right. And Dr. Shafi, and Dr. Shafi is also very active on Twitter. And one of the things which I learned through a lot of your tweets over a period of time also is that not only did you open the can of worms for SGLT2 use in MSLD, but it was a proof of concept for that. But it's also a proof of concept of the fact that SGLT2 does target ectopic fat in various other locations. So, what's your take on SGLT2 on the epicardial fat, which is again an important area of research, and the renal sinus fat, which is again becoming a very important area of research in terms of its renal protection effects?
Yeah. So, basically, we know that, insulin resistance is at the root of this disease, this metabolic syndrome for
Right,
visceral fat. And so there are, how does SGLT2 work? So I'll give
Right.
you 2-3 mechanisms, and then you will know what causes the shift in, this fat in different organs. And
Yes.
so when you give SGLT2 inhibitor, you cause more glucose excretion through the kidney. So
Correct.
there is decreased plasma glucose.
Correct.
There is decreased plasma insulin level, secondary to decreased glucose. It is as, simple as that. And in the liver, this decreases signaling of two important transcription factors. One is called SREBP1C, steroid responding element, and another is carbohydrate response element binding protein.
Right.
These two transcription factors, they are at the center of de novo lipogenesis, producing fat from carbohydrate in the liver.
Right.
So when there is low glucose, when there is low insulin level, there is low signaling of these two transcription factors, there is low fat in the liver. This
Right.
is one mechanism how it decreases liver fat. Second mechanism, very important mechanism, when you give SGLT2 therapy, there is decrease in insulin level because plasma glucose down, insulin
Correct.
level. It also causes increase in glucagon.
Correct.
It's known. So glucagon insulin ratio increases.
Correct.
It in the liver, it increases beta oxidation.
Right.
That is oxidation of fatty acids,
Right.
producing acetyl-CoA as a common, metabolite.
Correct.
This acetyl-CoA enters Krebs cycle for cellular energy needs.
Correct.
So from carbohydrate metabolism, it goes
There's
to
a
the
switch.
fat metabolism.
Correct.
And also this acetyl-CoA, which is generated by beta oxidation of fatty acids, produces ketone bodies.
Correct.
That ketone bodies through the circulation goes to the heart and to the brain, which use these metabolites.
Right.
So you are using fat from the liver now, which
Right.
is at the center of fatty liver disease.
Right.
So
So you're mobilizing the fat and you're using a separate fuel for the organs, right? So basically removing the
yes,
fat and
and this is the fat that is otherwise giving rise to fatty liver disease.
correct. Correct.
So now I will tell you the amazing mechanism, third mechanism. These are two
Right.
pathways
Correct.
which is known. Third is,
Correct.
as I had already shown in ELIF trial,
Right.
that the decrease in liver fat was not dependent on decrease in body fat.
Right.
It was very
This is a
important.
very interesting, again, this is something also which was landmark, Dr. Shafi, wasn't it? This was
Yes,
not
this was
seen earlier.
landmark at that time.
So you
This
were the
paper-
first to prove that you have the SGLT2 mechanism is not just because of the weight loss. There is mechanism beyond it. Yes, please continue. Sorry.
At that time, I was also, I thought it is some mistake,
Right.
but I was sure that I have done it very robustly.
Right.
The reviewers from Diabetes Care sent the paper back to me 3 times. Explain this. I said, this is data. I have no explanation.
Right.
So then editor-in-chief decided that it is to be seen in later studies.
Right.
So this answer was provided by another study, which is also now published in Diabetes Care, that was done by Stephanie Kuhlmann from Germany.
Okay.
they showed that empagliflozin treatment in insulin-resistant patients decrease insulin resistance in the hypothalamus,
Okay.
brain insulin resistance.
Right.
It decreases insulin resistance in the hypothalamus, increase parasympathetic activation of the nervous system,
Okay.
and through vagus nerve directly decreases liver fat.
Wow.
Well
Okay.
established now in subclinical as well as in clinical. This was done in humans. This study.
Right. Right.
They measured MRI. That what is that known as functional MRI
Yeah.
in the
Functional MRI and yes.
MRI and insulin resistance in the brain. They use nasal spray insulin so
Right.
that it directly reaches cerebrospinal fluid, and very elegant study. And it established the fact that empagliflozin, one of the modes of working is reducing
Okay.
insulin resistance in the hypothalamus,
Right.
increasing parasympathetic nervous system activation through the vagus nerve, directly decreasing liver fat.
Wow.
And same study said that the liver fat decrease doesn't depend on body fat decrease.
Right.
That I had
Already shown.
the observation that in
Right.
my patients this was the case, because
Right.
in 7 patients there was no fat, weight
Change in
decrease
weight.
in lift. There was no
Right.
change in that. Actually, in 2 patients there was gain of half a kg weight.
Right.
But
Right. Right.
they had liver fat decrease, significant
Right.
liver fat decrease.
Right.
That was an observation, but this was proven in 2030, now in 2021 in this German study. Very fascinating mechanism, and this is the only treatment, this SGLT2 inhibitor treatment that decreases hypothalamic insulin resistance. There is no
Wow.
other drug that decreases hypothalamic insulin resistance.
Not even GLPs.
No,
even GLPs.
nothing. No,
Not even GLPs.
no.
Okay. Okay, amazing, amazing. So I think this is fascinating again, and again, this is something which is, this is what great research really, shows. So again, dear audience, if you have any questions for Dr. Shafi, please post it in the chat. And Dr. Shafi, as you can see, this patient, the journey at 3 months. So this patient was started on a Dapagliflozin, and at 3 months, he did lose weight here. So he did lose about 5 kgs of weight. His HbA1c also came down. And you can see his liver is, the liver enzymes are also coming down. The SGPT, SGOT also falling, and even the GGT falling, right? And in your study, you did a MRI PDFF at the baseline and at the follow-up, right? So typically, you would also see a reduction in the liver fat on an MRI PDFF. And like you said, future studies would also, if you do biopsies, you will be able to find that fat reduction. The steatohepatitis would improve, and also in some cases the fibrosis also will start reversing in certain cases. So let me ask you, when you follow up these patients, of course MRI you did it for your research, but you would not do it in routine practice. Which of these parameters would you find most important in terms of acceptance as improvement in the MASLD?
So in short term, if your patient at baseline have elevated enzymes,
right?
So if you follow these after 3 months and there is decrease, certainly the patient is going improving.
There is improvement, yeah.
Yeah,
okay.
But one problem is in this: not all patients have liver enzyme impairment. You have only 20% patients that have increased liver enzymes.
Right.
All others may have significant MASH, significant inflammation. Still enzymes are normal.
Right.
And so, because you cannot detect inflammation, there is only biopsy that tells about inflammation.
Correct.
Only 20% patients where enzymes are raised. What will you do? Rest 80% patients. So that is why we need to, follow up these patients with fibroscan. But it's a short period, 3 months. You can go up to, after 6 months or 1 year. But if your patient has at baseline increased enzyme, you can follow enzyme after 3 months. That is okay.
Right. Okay. So, so you can follow up with enzymes, but just the caveat is that you have to be careful that there are certain patients where the liver enzyme elevation may not be there. Especially, would you agree that those are the patients where already they are slightly on the higher stage of fibrosis, where the liver enzyme elevation may not be there, but they're already developing some sort of, fibrosis, higher grades of fibrosis and cirrhosis, where the liver enzyme elevation may not correlate with the severity of the disease. In fact, the patient is already way advanced into the disease process, then liver enzyme may not reflect upon that. Okay, so let's take a next audience poll, and then we have also a couple of questions from the chat, which we'll just see. Okay. So let's just launch the poll. Second poll. Okay, so I think this is exactly the question which we asked to Dr. Shafi. After 3 months, Mr. Sharma shows improvement in glycemic control, liver enzymes with DEPA and metformin. What is the most important step for assessing MSLD response? So what would you consider doing this? Sir, what's your, I mean, let's say you're at baseline, you've done fibroscans, you looked at the CAP and the LSM values. Would that be a good approach to follow up in patients if the patient can afford, and if that's something which is available in your center?
Yeah, of course. What else do you have?
Right,
You don't have
exactly.
any other thing.
Correct, right?
Yeah.
So
Follow up by fibroscan till you have some reliable, modality. This is the only, because otherwise you have above that you have MRE. MR elastography. That is expensive, and it is only in some centers, and biopsy, which you can do. So till that we have some very reproducible biomarker, or some modality, imaging modality, which is available and accurate. This fibroscan is not, it has some limitations, but we have to accept those limitations, and we can follow with this, but not 3 monthly. That is it. Fibrosis is a process, it takes time. So I think if there is significant fibrosis and you want to see changes and you want to see the effect of your treatment, 6 months is minimum you should do, and otherwise annually is I think good. Yeah.
Right. Okay, and there's one more MRI which is now emerging, where you can actually see a little bit of steatohepatitis also being reflected. Is a CT1 MRI, the iron depleted. So about MRIs, since you again it was part of your trial, what do you require a specific what parameters would, of course, we are not, neither of us are radiologists, but again, from our knowledge, limited knowledge of radiology, what are the specific type of parameters you require in the machine, and what kind of machines can do a MRI, PDFF and an MRI elastographies?
No, okay. This is done with a similar MRI that you have in your hospital.
Correct.
Whichever MRI you have, 3 Tesla and whichever. Okay. So there is a software.
Right.
It is only a software that costs MRI, PDFF, MRI software costs 20 lakh rupees.
Right.
Again, for elastography, you need another software that costs 1 crore rupee.
Yes.
And they install that software, and then they take one scan and you get that. So it is a software. It is not some.
It's not hardware, right? So basically, but an expensive software to say the least.
Software.
Yes, right. Okay. So and also FibroScan is expensive. And also, please remember, I think actually FibroScan, one of the reasons why it's expensive is actually still patented, right? It's still under patent from one company, and that's the reason why these all things are actually expensive right now because of the patent regulations, right? Yeah. Okay. So moving on. Yeah. So I think we have one question, a couple of questions from the audience. So let's take a couple of questions from audience. And Dr. Sanjeev has asked about, and of course, there are other drugs, right? So let's take some of these drugs. Role of obeticholic acid, which is again, widely touted as a very important agent, and saroglitazar, right? Again, from our sponsors today, Zydus. Both of these drugs, your take, and another famous drug, the UDCA. These 3 drugs, where do you place them in terms of role in MSLD?
Okay, so first I will tell you, first I will give some insight into the disease, and then you can judge which drugs will work.
Right.
So most of the experts, they consider fatty liver as a pre-disease. Okay, if you have fat in liver, nothing else, no inflammation, no fibrosis, it's a pre-disease.
Right.
That is why if you see all the guidelines, they first do FIB4,
right,
first line, and then this LSM, the fibroscan,
right,
to take 2 different groups, one with fibrosis, one without fibrosis. And for without fibrosis, they say don't do anything, it's a pre-disease. Okay,
right.
So why is this? Because if your 100 patients have fat in liver, only 25% progress further to inflammation and fibrosis.
Correct.
75 don't progress over 2 decades.
Right.
So
right.
if you give only seeing fat in liver and give drug, you are drugging 75 patients without any reason or rhyme.
Right. Right.
Okay.
Right.
So let us say whenever you see fat in liver on ultrasonography, you see you can say that 75% are pre-disease and only 25% have disease.
Right.
That is
So
why-
just to say, the indication for treatment would be either steatohepatitis or fibrosis. So there must be some
no,
evidence,
no,
not just fat.
no.
Yeah. Yeah.
I,
Okay.
I will
Yeah. Okay.
put
Okay.
both things here.
Right. Okay.
So you have now you do scanning, you do fibroscan, and you say these are the 75% patient, these
Right.
are the 25 patient.
Okay.
So if you use, you don't have to use any liver specific drug in these 75 patients.
Right.
Because if you are giving drug here, you can prevent development of fibrosis in those patients.
Right.
It's a preventive treatment.
Correct.
And
Correct.
there are good long-term longitudinal studies, real world longitudinal studies saying that pioglitazone, SGLT2 inhibitor, GLP-1, they prevent development of fibrosis and inflammation in this group.
Right.
So
Right.
in those who have only fat, if you use these 3 agents, you are preventing development of MASLD and fibrosis and HCC later on. So here you do primary prevention.
Right.
Okay, right.
Right.
Now you have 25 patients who have fibrosis already. So
Correct. Correct.
this is the disease. They have
Right.
disease.
Correct.
Other 75 had pre-disease.
Correct.
So
Correct.
this 25 has disease. Now, what are the options of treatment of this disease?
Correct.
Again, these 3. Pioglitazone, because I saw for pioglitazone, you have PIVAN study.
Right. They also showed reversal of fibrosis there as well.
For this SGLT2 inhibitor, you have SNS trial now. We showed that 65% of patients, 63% of patients have MASH resolution. Okay. So, and I said they get in 1 month time, you will get DAPA study, which is a phase 3 trial, biopsy-based trial, which shows that Dapagliflozin improves this. So, okay. So you can use these 3 for prevention and you can use these 3 for treatment also. So,
Correct.
but if anybody, that is why resmetirom is indicated, the indication is F2, F3, not before that.
Correct.
Because
Correct.
it is for treatment, it is not for prophylaxis.
Right. Right. Right.
Similarly, if you have we don't have adequate evidence. So if you have adequate evidence for example, this saroglitazar, for other agents, for vitamin D, it will be only for treatment, not
Right.
for prophylaxis.
Right. Right.
So you can give that treatment only for those who have already developed fibrosis, because there is no evidence, you can't give for prevention.
Right.
For prevention, you have evidence longitudinal, one study done in UK, one in America, and one in Europe. Long term, 6 to 7 years follow up in thousands of patients. UK biobank database based. We showed that if you give SGLT2, GLP-1 in patients who have only diabetes and no fatty liver, it prevents development of fatty liver.
Correct.
And if you give in those who have only fatty liver, no inflammation and fibrosis, it prevents development of inflammation and fibrosis and HCC. So,
Right.
so you have to segregate your patients.
Correct.
And then think, are you giving this treatment for prophylaxis or for treatment? For treatment, you can use other drugs, even if there is less evidence, because you want to do something in those patients till
Correct.
you have firmly established therapy for that group. So you can, rationalize that I will give this drug, I will give this drug, but not for this who have only fatty liver and no fibrosis.
Correct. Correct. So great point. So I think it's excellent framework. So again, just to summarize, basically first you segregate your patients as having just like pre-diabetes and diabetes, so whether
Yeah,
your patient,
yes.
so if a patient already has pre-diabetes, but doesn't mean that you just leave them alone. You still give them some form of maybe lifestyle measures, maybe sometimes metformin, and to prevent them from developing diabetes and further complications. But those who already have diabetes at that point of time, or already have MASLD in this case, with steatohepatitis or fibrosis, in that case you offer them drugs which work in this specific group, like for example, now we have evidence with resmetirom, emerging evidence with SGLT2 and pioglitazone, and also some of the other drugs. So these are the groups where you would give them specific treatments because you want to prevent that from further progressing, right? So that's how. And let's just point here, SGLT2 now is increasingly being used in non-diabetic conditions, like for example, non-diabetic CKD and heart failure. Do you see it being used, since you are the foremost person who thought about this? And most of these trials, including your ELIF trial, was in diabetics. Would you do, would you now at this stage consider using it in non-diabetics also with MSLD?
Okay, there is a also trial in 2024 done by DeFranco himself. DeFranco, the famous person.
Right.
He did trial with empagliflozin
Hmm.
in patients who have
Hmm.
MASLD
Hmm.
with or without diabetes in both groups.
Right.
And
Right.
he found, it is also in diabetes care,
Hmm.
he found that there is decrease in liver fat in both groups.
Hmm. 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 Okay.
Okay, it is not only in diabetes, there is decrease in liver fat in both
Also in non-diabetic. So you
also in
can,
non-diabetes.
so you technically, theoretically, again, can use it in non-diabetic patients, but you don't have, just limited evidence right now. Just,
Yeah, one study only. Yeah,
right.
one
And
study.
the study from China, you said, is that going to be for diabetics or both the groups?
For 60% diabetes, 30%, 40% non-diabetics.
All right. So it's going to, you're going to show, the
Both,
study is going to
yes.
show evidence there. Yeah. So that's
Yes,
very
yes, both.
fascinating. So I think that answers a couple of questions from the audience also. And what about, I mean, let's say now you have a condition called MET ALD, where you have, MSLD, but patient also has moderate, degree of alcohol intake also. In such patients also, do you see, obviously SGLT2 has effect on the MSLD itself, but the alcoholic condition, does it have any benefit? Because some of the mechanisms tend to be very common, right? So is there a hepatoprotective mechanism there in alcoholics as well?
Yeah,
Yeah?
definitely. We
Yes.
had patients, for example, if your patient says that I am taking alcohol, okay, but we see he had obesity, he has insulin resistance features,
Correct.
everything.
Correct.
He has metabolic syndrome. So
Correct.
it was, you can't say it is alcoholic liver disease.
Correct.
Previously, because definition was such that if he takes such limit of alcohol per week, it is alcoholic liver disease. But what about his metabolic syndrome present?
Correct.
That
Correct.
is why
Correct.
this nomenclature
The
was
nomenclature has changed from
now.
non-alcoholic to MSLD.
Yeah. So
Yeah.
this particular patient may have contribution to MASLD from both alcohol and from metabolic syndrome. So it
Absolutely.
was not purely alcoholic, because the definition was if he takes this much of alcohol, he is alcoholic liver disease, because
Correct.
that was exclusion for non-alcoholic.
Correct.
So in this patient, definitely if you improve insulin resistance, whether you improve by this or reducing calorie intake and increase physical activity or GLP-1, he is going to improve. Yeah.
Okay, absolutely. So I think great insights. Like we already discussed, the ELIF trial showed 42% ALT reduction, weight loss, and also the important part was the MRI PTFF, where they showed the benefit of this. And we're just quickly moving because we're almost short of time. We'll like to take more questions. I'll just go through some of the aspects of this patient. And at 6 months, when we followed up this patient, there was further reduction in weight, overall 7.8 kgs. So there are certain patients who have, abnormal, I mean, sort of better results even with, and of course, lifestyle measures also. HbA1c further reduced, the ALT values reduced, and you can see there was improvement in the fibroscan parameters as well, LSM as well as the CAP values. And at 12 months, the improvements were maintained, and the HbA1c reports were also, again better, and the liver enzyme regained to almost normality. Right. So there was improvement there. Let's take an audience poll, and we'll take a very important question which Dr. Anand has asked in his in this chat. So at 12 months, Mr. Sharma has S2 steatosis and F1 fibrosis and fibroscan. So there's improvement. He's on metformin and DEPA. What is your long-term management strategy for this patient? Would you advise stopping DEPA would you refer to a hepatologist? Would you consider adding a GLP, adding pioglitazone on a continued therapy and monitor annually? Dr. Shafi, what would you do? So patient is showing improvement. Would you continue the drugs or discontinue, Depa? What would be your choice? I mean, the answer is
Yeah,
very obvious, but
it is,
let's, yeah,
it is
yeah,
obvious in our scenario because our
right.
patients have type 2 diabetes.
Correct,
This makes
correct.
it, easy for us because you
All
have
the more reason to continue. Yeah,
lifelong. If not
correct,
for MSLD, you have to give it for diabetes.
correct, correct.
For us, for diabetologists, for endocrine, it is a simple, we have to
Right,
continue lifelong
right,
medication.
right, right, right.
Yeah. For it becomes difficult in patients who are non-diabetic, for example, and they
Yeah,
have MASLD. So if they are on some therapy, they are, I am, always discussing with the hepatologists. They face this question that what to do, how long to continue. We don't have to face this question because we know he has to continue, for diabetes. So
right. So,
yeah, I will also okay. Why these therapies are important? Because when your patient develops fibrosis and inflammation,
right.
it is not only the risk factor for development of cirrhosis and liver related morbidity and mortality. It is independent risk factor for cardiovascular death, cardiovascular
Absolutely.
disease.
Absolutely.
It is an independent risk factor for CKD.
Correct.
It is an independent risk for atrial fibrillation,
Hmm.
liver fibrosis.
Correct. Correct.
If you minus all the risk factors, it's
In fact, these patients will die of cardiovascular disease before they develop cirrhosis also.
mostly.
So, yeah, so that's, yeah.
If you give SGLT, which drug reduces cardiovascular mortality?
Absolutely. SGLT2, right?
Which drug improves kidney
CKD
function?
outcome. Absolutely.
Yeah,
Right?
which does improves atrial fibrillation. So
Absolutely.
that is why this is not only treating one, it is you are giving one thing for so many things.
Right.
That is why this makes these special things. And similarly SGLT2, they improve all the things. They don't improve one target. They target so many endpoints that you are forced to give these therapies only.
Right. Absolutely. So great point. And sir, one important insight where Dr. Anand has asked, you talked about, patients progressing from from a fatty liver stage to a steatohepatitis or a fibrosis stage. From your knowledge, do we have any insights of which patients progress and which don't? Is there some way, which we know that there are certain patients who progress and certain patients don't?
Yeah, yes, we have many factors.
Right.
So common factors, if your patient has diabetes compared to non-diabetic MSLD, diabetics progress more.
Correct.
Okay.
Correct.
If you have older age patient,
Correct.
they
Correct.
progress more. And patient having multiple comorbidities of metabolic syndrome.
Right.
For example,
Right.
one group of patient has only type 2 diabetes and MASLD. Another has MASLD, dyslipidemia, hypertension. It will progress more.
Right.
Okay. So most important progression factor is genetics.
Right.
We have at least 4 these polymorphism synapses. One is called PNPLA3. Very important gene. If you have that variant, we call it MM variant, you are more likely to progress rapidly. Another is TM6SF2. This is another gene. And there are 4 genes. These 2 are very important. Another is, I don't remember. Yeah. There are other 2.
So genetic risk factors also is a very important.
And now it has become so important that now labs do this now. There are many labs that do routinely. So if you have a patient who has these two are more important, PNPLA3 and TM6SF2. If they have that particular variant, you are sure that they will progress. So you give aggressive therapy right from the beginning in those patients. So in the in coming years, 2-3 years, we will get more precision medicine
in terms of
so that which patients need aggressive therapy, where we can relax. Yeah, you get that thing.
Absolutely. Great insight again there. So again, this patient, so one of the things, Dr. Shafi, we are looking at this series is the long-term journey of the patient. And as you can see here, we're looking at the patient, at a 2-year, 3-year, 5-year follow-up, right? So this patient again, regained a little bit of weight. HbA1c still remained fine as, the ALT level is not normal. Well, 38 is still a little high, but still, thereabouts. So definitely improvement, the LSM and CAP value improved, and the patient also had significant improvement in his quality of life and other things. This patient, sir, lost a lot of weight with SGLT2. And I think we had this discussion earlier also in some other forum. There are certain patients who are very good responders in terms of weight loss with SGLT2. So again, any insights into that? There are certain patients who respond very well in terms of losing weight with that.
Yeah, I don't know the reason, but yeah, it's a
Right.
common observation.
Correct.
We have from 0 to 10 kg. Weight
Yeah,
loss.
yeah, yeah,
Some
yeah.
don't lose anything, 0. Some lose minus 10 kgs. Average is 3 to 5 kgs. We know
Right,
that.
right,
But
right.
some of I have discontinued SGLT2 in many patients because they complain that I lost more weight.
Too much of weight.
Yeah,
Right.
we have to
So,
discontinue that. So
correct.
it may be, depending on the receptor level, the channel level, and many other things. But this is a common observation. Yeah.
Absolutely. So I think we can at this point, sir, very clearly, establish that the benefit of SGLT2 in MASLD is a class effect for sure, right? It's not limited, though we did a ELIF trial. It's not limited to empagliflozin. It's in fact,
Yes.
Dapagliflozin also has a similar
Similar.
story. And in fact, like you said, the study from China where they use Dapagliflozin. So I think that may be more relevant again, equally relevant.
Not only we have studies for, we have 5 MRI studies for EMPA,
We
5
have Canna
MRI
also.
studies for DAPA.
Yes.
We have for Dapagliflozin, which is in
Yes,
Japan,
yes.
and another Dapagliflozin. We have one
Yes.
study for that. We have studies for all SGLT2.
All the SGLT2. So
Yeah.
it's a class effect for sure.
Yes, class effect. Yeah.
Yes. So a quick audience poll, and based on the current evidence, how strongly would you consider SGLT2 in for a type 2 diabetes with MSLD you require additional agent apart from metformin? I think very clearly established. I think laid the foundation right from the beginning that SGLT2 definitely has a role. So Dr. Shafi, I think this is your contribution to the world. I think the establishing this agent, right, in a disease which over a period of time, I still remember even in New Orleans when we met many years back, I think that time also MSLD was, I forgot even call MSLD, it was still emerging as an important area. Now it's in the news everywhere. Your companies developing, it's become a big thing. I think so. Definitely ahead of time. And I think again a great testament to a great innovation. So again, a very important thing that I think again the audience also completely agrees that very strongly. Yes, sir. Yes.
Over time, it has become very prevalent problem now.
Yes.
I did one study in my OPD for patients who come. I took almost 700 patients who undergo that advanced diabetes check,
Right.
and I did that. Everything in those patients, and I found that 7% of patients have compensated cirrhosis.
Right.
It's a big thing.
Big thing.
If you are seeing 102 patients and 7 patients, if you screen properly, 7 patients of cirrhosis in a tertiary care center, it may be low in community, but that's the huge thing. Your patient having cirrhosis of liver, and it is only visible if you do proper screening. Otherwise, you will not find anything. And sometimes they land up in emergency with upper GI bleed or cirrhosis,
In fact,
encephalopathy.
Absolutely. I mean, once you develop decompensated cirrhosis, what's the treatment, except transplant, so you don't have. So in fact, the only way you are going to, just like CKD, patient develops end-stage renal disease, what are you going to do? Either you're going to do dialysis or you're going to transplant them, right? That's it. You need to prevent. I think, so now you have these drugs, I think, which can actually prevent this patient from developing a disease where the only treatment is transplant, right? Which is quite, important, right? So in fact, even heart failure. Also. So absolutely. So when you have, end-stage heart disease, again, you have transplant, right? So you have, this thing. So again,
you have many countries in the world where MASH has become the leading one cause indication for, liver transplantation.
Absolutely. In fact, yes. So fast emerging away from hepatitis B's and C's and alcohol, MSLD is becoming a very important thing. So just, sir, final summary, some key take-home message for the audience with the focus on SGLT2, and then we'll take just a couple of questions from the audience and we'll end it. So just some key points for them to take home.
Yeah, if you are seeing diabetes patients, screen all diabetic patients.
Okay.
Don't do fancy testing. Just do FIB4, which you have. Everybody has those four parameters: A,
Yes.
platelet, AST, ALT,
Correct.
and see at least you know 70% of your patients will have a FIB4 of less than 1.3. And then you have small group of patients where you can see, you send them for fibroscan or any other whatever is available at your disposal. So you have to think that these 7%, 30% of patients may have compensated cirrhosis, may have
Right.
advanced fibrosis. So then you can take care of these patients. If your FIB4 is more than 2.67, so you if you don't have other modalities available, you directly send them to hepatologist and screen for other conditions. Don't ignore these patients. We have seen in the past that many of our patients which were following us for years, and one day they had frank decompensated cirrhosis, and then we you have to cut a sorry finger that yeah you have not done anything for so many
Correct.
years, and
They have
now
been on a follow-up.
this
Yeah.
cirrhosis. Yeah.
Yeah. Absolutely. Absolutely. Great. So I
So
think, and again,
screening is very important at our.
yeah, and I think one more thing I'll add to this. You said there are genetic variants where the fibrosis progression is very fast. That's not in our control. What is in our control is the other parameters. The type 2 diabetes, the dyslipidemias, the all the other things which add to the contribution to the progression. I think these things are under our control, and that is what we should be kind of focusing on and reducing to significantly reduce the risk of the patient progressing further, right? Because genes we can't control, but these things we can, right? I think yeah. So there are some nice comments in the thing. We'll just allow somebody, if anybody has a question, wants to unmute and ask to Dr. Shafi. We can take a question or two before we end this session. So you can just raise your hand and we'll allow you to talk if you have a question which you directly want to address. So while we take the question, sir, let me tell you, beautiful insights. I think it's always a pleasure talking with you. You are one of those ignited minds in endocrinology. So it's always a pleasure. And I think you started. I'll tell you. No matter what the world is, but I tell you from my perspective, you're a hero. You started the ball rolling for the use of SGLT2, very important drug for a very important disease, which now we are understanding the value of it ahead of time, absolutely. And I think well in line to achieving the desired objective of the original study, which was to really protect the patient's liver. So I think great job, great work, and great insight. So thank you so much for gracing this. I think we couldn't have had a better ending to a 4-part series. And Dr. Sameer, and any words from you, anything you'd like to add?
Yeah, so I think it was a great session. What I really liked about the series of webinars is it was not didactic, but it was purely case based. So at
Yes.
the end of the day, our audience would really get benefited for their ailing patients. The other small point that I wanted to add is today was a dual benefit webinar, as I would say it, because NAFLD has progressed to MASLD
Right.
over the last few years, and a long journey of SGLT2. Nobody actually thought that a drug which would be approved for type 2 diabetes about 10 years back would have approvals for CKD and heart failure and have promising results in MASLD. So in the metabolic space, I think today we had two great updates. And thank you, Dr. Om Lakhani. It was a very good way of discussing and learning things. So hats off to you. Thank you. And thank you, Dr. Mohammad. I think, you have added an icing to the cake because we did not only discuss cases, but you shared with us something which you started working quite some time back in this molecule area and therapy area. So thank you very much for sharing key
Thank you,
insights with the delegates. Over to you, Dr. Om.
Yes, thank you so much. So thank you, Dr. Sameer, and thank you again to Zydus for this. So this concludes the 4-part series. And like I said, if you want a certificate, go to technology.com, go through all the materials just one by one, answer all the quizzes, and you'll get the certificate. Also, you can contact your local Zydus representative. They'll give you a nice framed certificate of participation, which I'm sure will be useful. But more importantly, I think the knowledge which we had through the 4 sessions with an experts like Dr. Shafi, I think that's invaluable. So I think great insights. And Dr. Shafi, you're the icing on the cake. Thank you so much for being
Thank you,
there.
my pleasure.
And you'll always be my hero. You'll always be someone I look up to. And thank you so much again. Thank you.
Thank you. Thank you.
Thank you. It's
So thank you, everyone. Thank you to the audience for joining us for the 4-part series. This concludes the series, but we're not ending there. We are going to come up with a series on heart failure with Zydus again, with 4 cardiologists. Dr. Samir is going to be there right at the center of that. And we're going to have different areas of heart failure. We should be discussing deep insights, again, similar sessions. And we'll be integrating endocrinology and cardiology there. So that's where I think it will be very exciting. So we're planning that. It's in the stages, we'll have that very soon. And we'll be keeping you updated, right? So thank you again. And thank you to Dr. Samir for joining us
Thank you.
for all the sessions. And thank you to Siddharth is there. Right? Thank you, Siddharth, Mehul, from Zydus team for being there. Any words from the Zydus marketing team, Siddharth?
So actually, they are just returning from Bhopal, so
Okay,
they
so
are
they're
in a
traveling?
flight, correct?
Yes.
Yeah.
Okay. Great. So I think we can end here. And thank you again for everything. And we'll see you soon with the heart failure sessions. Thank you and good night.
Thanks. Good night.